EDIC Part 1 and Part 2 aspirants. Today's class is on acute kidney injury and it will be taken by Dr. Ranajit Chatterjee. Sir, I hand over the class to you.
Good evening, my dear friends. Without wasting any time, I'll start acute kidney injury for part 1, part 2 students. What I'll do, I'll discuss the part 1 part, the question types first, along with the theory part, followed by I'll take up a case from part 2, and any one of you, if you want to volunteer, you can come and give the answers, or I'll go on giving the answers. So it's up to you. If you want to do that, that will be nice. So acute kidney injury basically is a nascent terminology. It came in this century, along with this century. Previously, kidney injury was known as renal failure. Before that, it was known as Bright's disease. So during World War II and World War I, a lot of people died of crush injuries, and from there they developed acute. First of all, they had crush injuries, they developed acute kidney injury. That time they didn't have much of idea about exactly what is happening. By 1951, the first terminology came, it's acute renal failure. And by the end of this century, when the KDIGO guidelines started coming up, it was the first part of the century that we came up with this terminology, acute kidney injury. So the definition also came up, it went on changing. And for example, you will make, if you get a question like this, definition of the AKI this is for part 1, all right? I'll go for the questions first of all, part 1, followed by the part 2. Definition of AKI does not include increase in serum creatinine by 0.3 milligram per day within 48 hours. Increase in serum creatinine more than 1.5 times the baseline within 7 days. Urine volume less than 0.5 ml per kg per hour for 6 hours. And increase in serum creatinine greater than 0.3 milligram per day for 72 hours. So which one is right? So you can decide. Anyone can tell, you can discuss. It's difficult for me to see the chat box. Yes, very good. So answer is D. Fine. So go on giving in the chat box. That will be nice. So now, if you get, now see the definition, as you already seen, that increase in serum creatinine by 0.3 within 48 hours or 1.5 times the baseline in 7 days, or even volume less than 0.5 ml per kg per hour for 6 hours. So serum creatinine and urine output are the two criteria taken, the two biomarkers, you can say, markers that has been taken for acute kidney injury. So see the difference. It starts from 6 hours to goes up to 7 days. So 7 days is the cutoff. Beyond that, it is known as acute kidney disease. And after that, after 3 months, it is known as chronic kidney disease. So then the classification. Now 3 classification came up. Rifle classification in 2004, AKI in 2007, and KDIGO in 2012. All these classifications are still followed in clinical practice by clinicians. So they can ask you questions on any of these classifications. For example, even during your EDIC Part 2 examination, suddenly they can ask you a question, how can you classify acute kidney injury? So regarding the rifle classification of AKI, rifle E, that is E of rifle, represents early renal disease. Is this true or false? There is a Q type, there is a multiple type question. Kidney failure can be diagnosed by urine output alone. Criteria for risk, that is R, is highly specific, and serum creatinine is accepted as an index of glomerular function. So this is a true false type question. So E represents early renal disease? Obviously not. Kidney failure can be diagnosed by urine output alone? Yes, right. So no, you have to give true false. Prakash, give true false, not only B. So see, the answer will be no, not all is true. So E is represents E is the last stage, it's the end stage renal disease. So it's false. E does not represent that early renal disease. Kidney failure can be diagnosed by urine output alone, obviously. It can be diagnosed because urine output is a section. Criteria for risk is highly specific. In the in the upper segment is highly sensitive. The lower segment is highly specific. We'll come to that. And serum creatinine is accepted as an index of glomerular function. Yes, that's true. So you can also get a question like this. This is a general question on acute kidney injury. Hypovolemia is the commonest cause of acute kidney injury in the ICU. Is it true or false? Mortality is not significantly different between ICU patients with and without ICU. The prevalence of RRT in ICU is around 65%. And the vast majority of the survivors are dialysis dependent. Yes, A is true. A is not true. Hypovolemia is not the commonest cause, Prakash. Sepsis is the commonest cause of AKI in the ICU. Sepsis induced hypovolemia. So they have confused you by telling hypovolemia. Basically, the sepsis induced relative hypovolemia is the cause of AKI, not all type of hypovolemia. Yes, B is false, right? The prevalence of RRT in ICU is around 65%. Is this true or false? So this is also false. So everything is false here. Yes, right. Mohammed Raga, you're right. Everything is false here. The vast majority of the survivors are dialysis dependent. Wrong. Only 13.5% to 14% are dialysis dependent. Prevalence of RRT in ICU is around 30%. So you can get a question like this. Similarly, you can get a combination of questions between rifle, Acute, and KDIGO. They can compare each other and say KDIGO is superior to rifle in diagnosing AKI and predicting early and late mortality. KDIGO has a higher incidence of AKI. When you use KDIGO, the higher incidence of AKI than rifle and Acute. KDIGO is more predictive than Acute, but not rifle in evaluating in hospital mortality. KDIGO has a prognostic ability same as Acute and rifle. So you'll get a question maybe in EDIC part 1 like this. See, the first two are true, but the next two are false. We'll come to that. So we'll come to rifle criteria. You see, the upper risk injury and failure. The upper risk is highly sensitive. When it comes to failure, it becomes specificity increases. This is a criteria where creatinine, urine output, and glomerular filtration rate has been taken as a criteria for acute kidney injury. So glomerular filtration rate more than 25%, GFR more than 50%, or GFR more than 75%, or rise in creatinine from 1.5 to 2 to 3. This is risk injury and failure. Urine output accordingly 0.5 ml per kg per hour for 6 hours or 12 hours, less than 0.53 ml per kg per hour for 24 hours, or anuria for 12 hours. And loss and end-stage renal disease, they are also here in rifle. These two, the last two, has been removed by Akin and KDIGO. Akin also removed the glomerular filtration criteria. KDIGO only in stage 3, only for children, they have kept GFR as a criteria. So you should be knowing all these criteria as well. Then only you can go for a good answer for the questions that will be coming. Remember, it did not aim to trigger standardized therapeutic intervention. It did not aim to predict mortality or adverse outcomes. These questions have come. So that is the reason I have highlighted them. And hospitalized, now this is validated, already validated on a big number of patients in ICU. Now, this is in criteria. How the change occurred. Acute has given a 48-hour time frame and a small change, even a rise of 0.3 milligram per DL from the baseline. This from here it came in 2007. That small change in serum creatinine, it is trying to sensitize you to the rise of serum creatinine. Small change, for example, from 1.1 to 1.4, the patient is already moving to acute kidney injury. So this part is very important. KDIGO basically combine these two and see the fourth, and the definition was also given here. And see, acute decrease in eGFR to less than 35 ml per minute for 1.72 meter square is the criteria for stage 3 AKI. So here it came only for children less than 18 years of age. So the GFR staging for less than 18 years of age. Rest of them more or less is the same. And when they studied these three on different patient categories, they found KDIGO superior to rifle in diagnosing AKI. KD has higher incidence of AKI than both rifle and AKI. In evaluating in hospital mortality, KD was more predictive than rifle, but not that of AKI. And it has an overall superior prognostic ability. So a question may come on this slide for EDIC Part 1 patients, aspirants. So now you should know what is NKD. There is no kidney disease. AKI up to 7 days, the criteria has been told. AKD, here when you define acute kidney disease, it is 7 to 3 months. Here GFR, see the criteria. AKI or GFR less than 60 or decrease in GFR by more than 35% or increase in serum creatinine by more than 50% for less than 3 months. And there is no structural change. The moment the GFR decreases below 60 for more than 3 months with a structural change in the kidneys, we define it as CKD. So the definition has been given, quite specific definition has been given, specific time frames has been drawn. So questions might come from here that what is AKI, what is AKD, and what is CKD. Now, after we have gone to the diagnosis of the definition of AKI, classification of AKI, let us go to the diagnosis of AKI. As we all know, AKI can be we still follow this criteria of renal failure, that is, it may be pre-renal, renal, and post-renal. So the values indicate pre-renal acute renal failure. Fractional excretion of sodium is less than 1 or more than 5, less than 5%, 10%, less than 10. Or fractional excretion of urea less than 10. Which one is right? Yes, right. Now, what is fractional excretion of sodium? Archana, you are also right. So, what is fractional excretion of sodium? Urinary sodium by serum sodium divided by urinary creatinine by serum creatinine into 100. If this is less than 1%, that means the patient is in acute renal failure. But there is a rider here. If the patient has received already a diuretic like Lasix, then this criteria does not hold any good with renal acute renal failure. The moment you give diuretic, the fractional excretion sodium will increase because sodium will come out with the diuresis. So you may get a question like this. The following rules indicate renal acute renal failure in the presence of diuretics. Fractional excretion of sodium less than 1%, urea less than 35, uric acid more than 8, excretion more than 5. Which one is the answer? So, yes, Mohammed Raga, you are right. Archana, here, just you missed it. Here we have to see the fractional excretion of urea because it doesn't get affected with the diuretics. Again, urinary urea by serum urea divided by urinary creatinine. Yes, Hiran, you are also right, by serum creatinine into 100. So here we find that the urea, the fractional excretion of urea has to be taken. Now, this is a type question. Now, you will get a different type of question like this, a difficult one, maybe a bit more. Now, see the question properly. A patient of cirrhosis came with altered sensorium. The urinary parameters are as follows. You may also get a question like this in EDIC Part 2 also, with a detailed one, a bit more one. Now, fractional excretion less than 1%, urea less than 25%, creatinine urine by plasma more than 40 by 1, resistivity index, renal resistivity index less than 0.76. Patient was put up on ventilator and the delta PPV was found more than 3.5 following tidal volume challenge. The patient is suffering from volume response is pre-renal ARS, volume response unresponsive AKI, hepatorenal syndrome, or post-renal acute renal. Which one? Narsina has given an answer. Anybody wants to give any other answer? Anyone? No? So yes, you are right. Absolutely right. This is volume responsive renal. How? Why it is? See now. See the question very, very carefully. This is a patient of cirrhosis. So in cirrhosis, you have two types of renal failure: the pre-renal renal failure and the hepatorenal syndrome. They look exactly similar. Exactly similar. Now, they will have fractional excretion of sodium less than 1%. They have urea less than 25%. Everything will be fine, except for the renal resistivity index. In hepatorenal syndrome, this will be more than 0.8, whereas here it is less than 0.8 or 0.75. So here, so it is a pre-renal acute renal failure. From here up to here, I have diagnosed. Now, whether this is volume responsive, that is been given by the answer by delta ppv. If delta ppv, that is the change in pulse pressure, the pulse pressure volume variation, I'm sorry, ppv is the pulse pressure variation. When you are having this, what is happening basically? You are giving a tidal volume of 6 ml per kg body weight in the ventilator. Patient is body weight. And see the change in the pulse pressure variation in the PP. So if it is more than 3.5, that means this patient is a patient of volume responsive. If it was less than 3.5, it would not be responsive. So from here, the question has arrived. So the answer is A. Now, this is a very important part. Everybody is trying to follow this regarding FST, fusimide stress test. How much dose to be given? 1 milligram. This is a K-type question. For patients who have already received diuretics, the dose is 1.5 milligram per kg. Urine output less than 200 ml in 2 hours is indicative of severe AKI. It helps in AKI treatment. So this is true, 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 or false, 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 true, false, true, false. What is the answer? Anybody try? Archana? All right. Anybody else? Prakash has also given an answer. Sweta has given an answer. Good. Everybody is trying. More or less, you are right, except for the fact. Yes, many of you will ask, Archana, you are also, you may get a number here, but you know, when it helps in AKI treatment. How? Because it gives you an idea that the patient is moving towards severe AKI. Elias, you have to, the second one is false. That means, Elias, you have to go and read fusimide stress test, because fusimide stress test, we give 1 milligram per kg body weight. Those who have received diuretics, we increase the dose to 1.5 milligram. We check the urine output for 2 hours. If it is less than 200 ml, it is moving towards severe AKI. And that helps in our treatment, that we will get ourselves ready, that now we might have to move towards renal replacement therapy. So all of these are correct. Now, regarding diuretics, it should be used in AKI with volume overload. It should not be used to prevent or treat AKI. It should be used to prevent AKI, but not to be used for treating established AKI. And fusimide stress test is done to assess the severity of AKI. What true, false, K-type question. What do you think? See, whatever you're reading in EDIC part 1, it might get translated into EDIC part 2. There is not much of difference. So you should be knowing the whole subject very well to answer EDIC part 2 well. When I come to the questions of EDIC part 2, you'll understand that. You please give the answers. Nobody? Anyone? Yes, right. True, true, false, true. True, false, false, false. True, false, false, true. So see, it should be used in volume overload. There is no problem in that. It should not be used to prevent or treat AKI. This is very important. Very important. It should not be used neither in prevention nor in treatment. It should be used to prevent AKI but not used to treat it is obviously false. And fusimide stress test is done to assess the severity. I've already told. So the answer is true, true, false. Now, this is another question. You will get a difficult type of question here, like this. While evaluating a 23-year-old female patient who presents in the emergency department for a marathon, it was found, see, now he is going in a marathon. That means they'll give you some hints. The patient is already dehydrated. It is found that she is lethargic and hypotensive. Want to know. Serum sodium, they have given potassium chloride, CO2, urea, creatinine, they are giving a osmolality. Now see, you've given an osmolality, they've also given you urinary sodium and urinary creatinine. What they want to try to derive? They want to derive, you have to take out the fractional excretion of sodium here. You know that the patient is already dehydrated. Then means now they want to see whether this fractional excretion of sodium is less than 1% or more than 1%. That means whether the patient is still in a hypovolemic prerenal acute renal failure or already acute tubular necrosis is developing. So if you calculate it, you'll find it is much more than 1%. So the answer is acute tubular necrosis here. Did you get it, the answer? Yes. Now, Srina, I've already told this is acute tubular necrosis. So you have to understand how the questions has been given. If you understand how the questions are given, then you have no other difficulty but to answer the questions. Sorry. Where are my slides? I'm not getting my slides again. It has gone down. Somehow the slides are. Let me see. Yes, yes. It is coming. Just wait. I don't know. It is not coming. So I'm again stopping my slides and again going to share it with you. Just wait for a minute. Yeah. Right. By this time, if you have any questions, you can ask me directly. Fine. So see, when the diagnostic indexes of azotemia has been seen, this table is still followed. And the fractional excretion, go to the lowest part of it, fractional excretion of urea, uric acid, and lithium. They have been also used for to see whether it is a prerenal or renal failure. I'm not going into the details of it, but you should remember that whenever you are in a pre-renal or a renal disease, do an ultrasound, see if the normal size kidney is just set for a blank urine. They will ask you, what is the urine test you want to do? I want this. You will just have tubular casts. In eosinophilic glomerulonephritis or a case of multiple myeloma. So these type of only the simple cast will tell you about the disease. So very simple way of diagnosing acute kidney injury. We don't have to go for very big things. And very simplest way of diagnosing is the easiest way is to get the urinary casts. So now the point is both urine output and creatinine has its own pitfalls. So they do not basically, by the time creatinine rises, 50% of the kidney is gone. So we are in search of more biomarkers. And one of these biomarkers is a multiplication factor of TIMP2 and IGFBP7. Tissue inhibitory metalloproteinase 2 multiplied by insulin-like growth factor binding protein 7. So basically, this is also known as nephrocheck. There are many others. I'll come to that. But why I am telling this? Because this is the latest one that is in the market. So you'll be asked the questions about. So if you don't know, go for this. Or if you know about it, answer this question. It is a cell cycle arrest marker. It is measured in the serum or in the blood. Values less than 0.3 indicates developing AKI stage 2 and stage 3 within 12 hours. And bilirubinemia more than 7.2 milligram per day will interfere with the test results. Any of you, can you answer? It is a true, false type question, Q type question. Hello, please answer. No one? So this is a cell cycle arrest marker, all right? And it is measured in the urine, not in the serum. And the values more than 0.3 indicates that the patient is going to develop AKI. And definitely bilirubin, high bilirubin interfere with the test result. It's a very important question for EDIC part 1. You will definitely be asked about this. So they may ask about this also. They may just change the pattern of the question. They'll ask you regarding biomarkers. NGAL, KIM1, and interleukin 18 are damage markers. The values more than 0.3, I've already told you, of TIP2, IGBP7 is predictive of severe renal disease. Cystatin C and proenkephalin are functional markers, and DIC of 3 is a stress marker. Now, nobody have heard about this, but definitely it is there in the market, so I've given it to you. So if you don't answer, I'll go for the answers here. Say they have basically complicated this whole thing. Here, IL-18 is an inflammatory marker. It's not a damage marker. NGAL and KIM1 are damage markers. The second one is right. Cystatin T and proenkephalin are functional? No, because proenkephalin again is a inflammatory marker. And DICOP3, two stress markers are there. One is IGFBP7 and TIMP2, another is DICOP3. So you have to remember these two stress markers which are there to diagnose acute kidney injury. So there are a lot of pitfalls of creatinine. I'm not going into the details of that. You should know about these biomarkers, that is, which is the biomarkers for glomerular function, which is the markers for inflammation, and which are the markers for damage. You may get a question on NGAL because NGAL is being widely used now in most of the centers, including ours, where we have found both urinary and the plasma NGAL cutoffs indicate that the patients are at a high risk of AKI. So this is very important. NGAL, that is neutrophil gelatinous associated lipocadine. This is a 25 kDa protein which is secreted from the proximal tubular cells and also by the neutrophils. Very, very good marker, very good marker for acute kidney injury. Again, this is TIMP2, IGFBP7 more than 0.3 indicates within 12 hours the patient might develop severe AKI, or less than 0.3, you don't have to worry much. And there are certain limitations. Two of them you have to remember, the last two, nephrotic range proteinuria and bilirubinemia. Remember, it has limited published data on less than 18 years of age. Now, this classification, according to the biomarker given by Westerman Merlin, has given excellent classification. So, but she doesn't know because we were there in the same chair in 2022. We go on frequently meeting each other in the conferences. I asked her, you have given this very good classification, but which biomarker you were telling? She didn't know which biomarker, but once the biomarker is, first of all, we stick on that, yes, maybe nephrocheck, then we can get a classification like this. One, but creatinine and urine output is problematic, and both of them are problematic. It is basically 1B. Similarly, 2A, 2B, and 3A, 3B. Now, furosemide tested, I've already told you, see the sensitivity and the specificity, and improve severity of AKI predictability if I combine it with NGAL or TIP2, IGFBP7. One very important point here. It should be used only in hypervolemic AKI, stage 1 and 2, not in hypovolemic AKI. So first of all, your fluid resuscitation should be enough so that you can give furosemide. The patient should be hemodynamically stable to use this. So these are the two very important limitations of this test. This is a Malhotra's classification. The important part is the negative predictive value. See, the negative predictive value is 95%. So the question will come on the negative predictive value rather than a positive predictive value. Similarly, two indices, renal angina indices. Here it is basically a multiplication factor of two scores. If the by creatinine less than 0.1, more than 0.1, more than 0.3, more than 0.4, it is increasing. Score has been given 1, 2, 4, and 8, so whittle to 5. So multiply these two factors and get the renal angina index. If it is more than 8, you have a persistent severe AKI. Within 1 week, you might develop an AKI, severe AKI within 1 week. And again, if I combine it with renal angina index plus some indices like LFABP, these are the biomarkers, it has been found that improved prediction of severe AKI. Similarly, there is another index known as persistent AKI risk index. Again, see the negative predictive value of 93. That what is the negative predictive value or positive predictive value of this type of classification? This is very important. I don't know how they'll formulate the question here, but this is the latest concept that they have given by Ronco. How they have basically the AKI biomarker composite. They are basically as like in the arterial blood gas, PA stands for hemostasis, your urine output stands for the renal hemostasis. PO2 stands for solute. Marker of tubular damage similarly is the NGAL. Reserve is by can be seen by fusiform stress test, or compensation can be seen by your the fluid overload percentage, and the system stress can be seen by that is because it's a stress marker. I guess maybe they will formulate a question on this, so you should be knowing about this. So regarding diagnosis of API, serum creatinine is a sensitive marker. Urine output is a specific marker. Combining renal angina index with LAFM improves diagnostics more than 8 has a positive predictive value of 93.9%. I discussed the whole thing now. I've already discussed what should be the answer. A-type question. Anyone? No answers. So it is becoming a bit difficult because you will get difficult questions. So serum creatinine is more a specific marker. Urine output is a sensitive marker. Combining renal angina index with LFAVP improves the diagnosis, true. And I have already told that indices have a more negative predictive values. The answer is this will be a negative predictive value of 93.9%. So this type of questions you'll be getting. So very quickly to the prevention of AKI, you should be knowing about this question because these are typical questions that might be given because of the KDIGO guidelines. So regarding serum level of aminoglycosides, which one is true? To be monitored every 48 hours in single daily dosing, should be monitored every 48 hours in multiple daily dosing, does not require monitoring, should be monitored every 72 hours. I've already given you the answer. Should be monitored every 48 hours in single daily dosing. Many people still now follows a double dose, which is not right. But still, if you are giving a double dose, there should be a 24-hour monitoring. So I'm leaving all this. Remember that nutrition, while you're following AKI, you should not restrict the protein if the patient is not in CKD. The protein intake should be increased if the patient is in CRRT up to 1.7 gram per kg per day. So this is very important. The KDIGO guideline that has been given. And remember about pre-renal AKI and hepatorenal syndrome. I've already told you this difference will come. Cirrhosis with ascites, serum creatinine 1.5 milligram per DL, absence of shock. So in the situation of cirrhosis with ascites, if the creatinine is rising, if there is no shock, toxic medications which has been given, and if there is no renal parenchymal disease which is defined by proteinuria, hematuria, and renal ultrasound. So if you have all these negative and a renal angina index and the resistivity index of more than 0.8, then only you will say that this is hepatorenal syndrome. And obviously, you know the treatment is volume expansion, 20% albumin followed by vasopressors, either terlipressin or noradrenaline. Question might come, which one is better? It has been found both of them are equally effective. So you can get a question like this, see, regarding now contrast induced AKI, I don't, they're very, because contrast are used all over the world now. So this is very important. See, it consists of, I've already given you the answers for this. It consists of 11% of the hospital acquired AKI. Remember, it is 11%. Mortality is as 34%. So, and theophylline, many people were using theophylline. It is not recommended nowadays. Colloids are never recommended. Oral NAC are still used. So the treatment is basically crystalloids and oral NAC. So, like this, A-type question might come. Theophylline has been found to prevent contrastive AKI. No. Phenoldipen has been found to be superior. No. Using oral NAC and IV isotonic crystalloid is a patients with increased risk of AKI? Yes. And using IV NAC and IV isotonic crystalloids in patients with increased risk of AKI? No. Oral NAC is sufficient. So you may get a question on contrastive AKI. The definition is more or less the same. They'll not give a question on definition. They'll give a question on the percentage of patients going into AKI and the mortality percentage. Remembering 2 points, isotonic crystalloids, NAC, no role of prophylactic intermittent hemodialysis or hemofiltration here. So now I come to a case where I'll give you a case and you see the case, and this is basically a case based. This is a EDIC type 2 case that I'm going to discuss. And I'll go on further discussing the types of therapies regarding to this. Anyone want to volunteer this? Anyone? Any one of you? Then you can unmute yourself and volunteer.
Yeah.
No? No one?
Okay, sir.
No one? Yes, I can hear you. You are basically echo is coming. I'm getting a lot of echo.
Same phone.
Are you also getting my voice echoed?
No, because I open on desktop and on my
Yes,
phone
sir, echo
also.
आ रही है.
इको आ रहा है ना? मेरा भी इको आ रहा है?
अब बंद हो
So
गया सर.
somebody else can manage. Somebody else.
So all of you can participate. There is no problem. Now see, a 26-year-old car mechanic suffered from fever and cough for 5 days. Very simple. They'll give this type of question on 5 days. So fever and cough. So obviously what has happened?
Infection.
Fever and cough.
Community acquired pneumonia.
Exactly, community acquired pneumonia. So he ignored it initially, what happens normally. But when the respiratory distress increased, he came to the casualty. But his saturation deteriorated to 70% on 0.5% 0.5 FiO2. GCS came down, mean arterial pressure came down, pulse rate increased, respiratory rate increased, chest bilateral creps. Patient was taken in the ICU, patient intubated and put upon mechanical ventilation. Cultures taken, ABG done, antibiotics started, fluid restitution given, vasopressor started, and investigation set. Everything has been told. High anion gap metabolic acidosis, see the lactate level 7, PO2 FiO2 150. See the serum creatinine 1.8, urine output after 6 hours of 30, creatinine increased to 2.8 after 24 hours. So what? The question will come, they'll give you specific 5 questions. What is your diagnosis? How do you proceed in this case? How do you decide renal function? How do you proceed with RRT? And how do you proceed with nutrition in this case? Now, the point is, when they ask you diagnosis, there will be a single one. But the moment they go to the other questions, they will divide the questions to different parts. For example, now see, what is your diagnosis? What is your diagnosis?
Type 1 respiratory failure, most probably community acquired pneumonia with hypotension, probably septic shock.
Why probably? So do not give any answer like probably. Be very specific in your answers. All right, don't say probably. You are right. You are telling the right thing. But do you want to add anything to this? Please see.
Septic shock.
With AKI and high anion gap metabolic acidosis.
All right. Can you stage the AKI? We have already read the staging. So
Yes,
see,
yes,
the
yes.
more you classify your diagnosis, the more better impression that you create for the examiners. Yes, he's maybe in his sheet the answer will be community acquired pneumonia. hypoxemia, which is severe or moderate hypoxemia, PO2, FiO2 150, isn't it? Lactate level is 7. So definitely the blood pressure, the mean arterial pressure is 55. So these two are indicating septic shock. Yes, you are right. And you have a Kedigo stage 2 AKI. So when you diagnose, you give like this. All right. So stage, tell everything. There is no problem. So yes, you have gone to this. Now your diagnosis is right. How do you proceed in this case? You have already taken the cultures. So you take the cultures first. Then you start with the antibiotics within the first 1 hour. And you start with the ventilation. They may go into the ventilation, but you say, I've ventilated the patient. How to give fluids? They may ask, the question may ask, how to give fluids?
Fluids
Anyone?
given as per the dynamic indices.
All right. So I go for the dynamic indices. To which fluid do you select?
Crystalloids, and among that, balanced crystalloid will be preferred.
So I select, very confidently you say, I'll select crystalloids. So whenever you say crystallite, you say balanced crystal, you also say the dose. But approximately I'll give this.
As per the Surviving Sepsis Campaign guidelines, 30 ml per kg should be given in the first 3 hours. But
So what to start crystalloids? Yes, you're right. How much crystalloids? 30 ml per kg. Time frame 3 hours. But this is a weak recommendation with low quality of evidence. It may be too high for patients of CHS of CKD. It may be too low for patients of GI sepsis. I have to individualize. All right? You're right. Absolutely. Now, which type of crystalloids? Balanced crystalloids or normal saline? Yes, I'll give balanced crystalloids, but the Surviving Sepsis Campaign went for balanced crystalloids based on the SMART and the SALT-TD trial. Followed in 2021, they didn't consider the PLUS trial and the basics trials that came afterwards. They showed no difference between balanced crystalloids and normal saline in resuscitation of sepsis. I will select balanced crystalloids, but if I don't have balanced crystalloids in my hand, I can jolly well go for normal saline. All right. And is somebody you already told that, yes, I'll go for my initial resuscitation on the basis of my hemodynamics. I'll see my dynamic parameters. You are absolutely right. Pulse pressure variation, stroke volume variation, maybe the plethysmographic variability index, the PLR, that is the passive leg raising test, the EOs, the EIOs. Now the point is, serum lactate. The new thing that has come up is the capillary refill time. That is the Andromeda shock trial. It is showing if it is more than 3 seconds, we want to achieve less than 3 seconds. And we have to achieve a mean arterial pressure of more than 65. Now, we can also go for a dynamic variation of delta PPV that I was discussing by increasing the tidal volume from 6 to 8 for 2 minutes. And then we see the change in the pulse pressure variation. If it is more than 3.5, that means this patient might be fluid responsive. Remember, pulse pressure variation, stroke volume variation has to be done in patients who are paralyzed, has to be done. Is this pulse pressure variation is a very good dynamic measure in this case? Anybody? Do you think that pulse pressure variation is a very good dynamic measurement monitor in this case?
No, sir, because the patient is receiving a low tidal volume, ARDS protective lung strategies.
Yes,
should
because
receive 6
pulse
to 8.
pressure for pulse pressure variation, your chest should be, you have a good tidal volume. Number one. Number two, if your patient is in ARDS, your pulse pressure variation will not be accurate. Number third, you have to paralyze your patient. Number four, there should be no arrhythmias in pulse pressure variation. It will change. So you have a lot of problems here. Here you have the patient already, I think there is some lung compromise. ARDS, you go for a low tidal volume ventilation. Any of these indices, pulse pressure variations, stroke volume variations, plethysmographic variability index will not work. So I have to go for my PLR. I have to change, I have to see. And in resource limited circumstance, even a change of more than 15% is the pulse pressure. Pulse pressure, not variation, pulse pressure. After a PLR of 60 to 90 seconds, the patient might be fluid responsive. So we can also see, this is the skin mottling that we have seen. That is also there, which correlates well with lactate, urine output, organ dysfunction, and mortality. And if you have from the Andromeda shock, we have seen the capillary refill time is more than 5 seconds, there is worsening of organ function, good predictor of short-term mortality. Less than 2 seconds in normal, anything more than 4 seconds in abnormal, they have more or less the 3 seconds they have given the criteria. So now I have given fluids. They can ask you the next question, how to give vasopressors. So I have given fluids. I can also see the skin temperature gradient. Sometimes it is seen. A question came, so I've given this. Poor sepsis outcome with the skin temperature gradient between the tip of the finger and the middle of the thumb is more than 4 degrees centigrade. It also shows fluid deficit. Also, a change is more than 5% on the ETCO2 by doing a passive leg raising test. ETCO2. That shows fluid responsiveness. You all know about the collapsibility index of the inferior vena cava. For spontaneous patients, more than 50%. For patients who are on ventilator, either 18 or 12%. It depends on the denominator you have taken. You have taken the mean or you have taken the minimum. If you've taken the minimum, then it will be 18. If you've taken the mean, it will be 12. So this is the way how you decide on your dynamic parameters. Now, when to start vasopressors? So even after giving the fluid, now, do you go for colloids? Anyone in favor of colloids? Can you resuscitate the patient with colloids here?
If large
Nobody?
fluid volume resuscitation is given, then we can give albumin. Otherwise,
Very good. See, if we, otherwise, albumin, large volume crystalloids, albumin, weak recommendation. But for starch, the YSF 6s and the chest trial has shown that starch might be causing a lot of not only renal replacement therapy and or mortality. But there are very good papers, Crystal paper, Bassis trial, Fast trial, Christmas trial, were in favor of starch, but they have been ignored by the surviving sepsis. And nowadays, starch is recommended against. There is a strong recommendation of high quality evidence. The starch should not be used. So this is a debate that I'm not going into the debate of this, because there are a lot of shortcomings about these 3 trials, which basically was the nemesis for the colloids. In YSEP trial, they used a hydroxyethyl terms of 200 by 0.5, very high molecular weight. It is already, we know, that is causing renal failure. Moreover, 59% of the patients already received starch before randomization. I don't know how to. Similarly, the 6S trial was there, Scandinavian trial. They maybe asked you the trial in EDIC 1. So 6S trial, they found that the fragility index of the trial was 2. That means if you shift 2 patients from one group to the another, the whole trial would have changed. There, in this trial, they found there is not only increase in renal replacement therapy, but also mortality. But the chest trial, which came from Australia, it found that there is no increase in mortality, but only increase in renal replacement therapy. সালাউদ্দিন ভাই, একটু বন্ধ করুন আপনার এটা, আপনার মিউট করেন নিজেকে. Rifle R and Rifle I are more in normal saline, and Rifle F is more in hydroxyethyl starch. Rifle R and Rifle I in normal saline reach statistical significance, but Rifle F, that is a failure, never reached statistical significance with hydroxyethyl starch. How come RRT reached statistical significance? It is $1 million question. That means they might have started certain cases in Rifle R and Rifle I, but these questions will not be asked. But this is for your knowledge that I'm telling you. Whenever you go to some debate or they might ask you a question in the EDIC part 1, but I don't think that they'll ask you. But obviously, you should be knowing about this in details. So when to start your vasopressors, and which vasopressor you want to start?
Norepinephrine.
Norepinephrine you want to start. And suppose you don't have central line. Can you start through the peripheral line?
Why a large bore cannula? If cannula is patent, then we can start with a low dose vasopressor by peripheral line.
Then within what time, Nidhi, you want to put a central line?
Within 15 to half an hour, we can put.
So that means you have not read you have not gone through the campaign properly, isn't it? So you have to
Yes.
put it. Yes, you have to put it within. I'll show you. If it is there, I'm sorry you don't have the slide. That slide with me. You have to put it within 4 hours. All right. Till 4 hours, up to 4 hours, they are telling you can go to the non-epinephrine through a peripheral large borderline. You are right. But up to 4 hours, you can go up to that. But beyond, do not. Yes, you are also right. You have to say that if you answer this question, Nidhi, like this, I'll put the line as quickly as possible, because there's every chance that the patient might go into gangrene. So you can say like this, you will get the full marks. But do not give that 15 or the 30 minutes. Try not to give certain figures. Try to say, I'll try put it as quickly as possible. Maybe if you know the answer, then you say, maybe I may go maximum up to 4 hours. This is the way you go. All right. Now, when do you start non-adrenaline? Early. So you see if the diastolic blood pressure is going down below 40, then you go for the diastolic early non-adrenaline start. And you do not exceed 0.5 microgram per kg per minute. Once you exceed it, you start the second vasopressor. Which second vasopressor you want to start? No one?
Vasopressin.
Fantastic. Vasopressin, what is the dose? So vasopressin 0.03 units per, yes, 0.03
Okay.
units per minute. So when you, so you have given non-adrenaline, you have given vasopressin, your blood pressure is still not coming up. It is still below 65 mean arterial pressure. You start steroids. So start steroids, either hydrocortisone or yes, hydrocortisone, either 200 milligram per day or 50 milligram 6 hourly, or a continuous infusion of 10 milligram per hour, but within 4 hours. If that is beyond when you have given non-adrenaline for 4 hours and still the blood pressure is not coming up, then you start steroids. Now you have achieved your blood pressure. You have achieved your blood pressure, but still you see that your cardiac index is not coming up. So then what do you start? Or they can ask you a direct question. They can ask you a direct question. When to add inotropes? The question number 5. When to add inotropes? So now you are giving vasoactive agents, vasopressors. Now I have to give inotropes. Remember, I'll start inotrope once I achieve my mean arterial pressure more than 65, and still I have a cardiac index of less than 2.1. But if I don't have an ultrasound echo, then I can't find my cardiac index. I see a delta PCO2, that is the difference between the PCO2 between the arterial and the venous gas. And if it is more than 6 millimeter of mercury, and it's still SCVO2 I have achieved maybe more than 70, hematocrit is more than 30, I start by dobutamine. Levosimentan has no special advantage over dobutamine. So this is another thing. So I start by vasopressors here. Now, when to start CRRT? So this is a question. When to start? Because you want when to start RRT. So RRT may be a CRRT or maybe a IRRT, that is the intermittent renal replacement therapy. So CRRT is a continuous renal replacement therapy. The intermittent one is either intermittent hemodialysis, sustained low efficiency daily dialysis, or your peritoneal dialysis. If the patient is hemodynamically unstable, here the patient was hemodynamically unstable. If the patient is volume overloaded, if the patient is developing potassium, see with the question the potassium was 7. If you come here, you will see the potassium was 7. Your patient was already in metabolic acidosis, 7.1. Your patient has already reached a creatinine of around 2.8, going towards second to start stage. So this patient is having 3 indications and the patient is in septic shock. So the patient is hemodynamically unstable. So I start here continuous renal replacement therapy rather than considering intermittent renal replacement therapies like SLED or IHD or intermittent hemodialysis. Remember, it is in kinetic resistant pulmonary edema, brain injuries. It may be an adjuvant therapy to sepsis because it removes the middle molecules. And there is some observational studies, not randomized control trial, showing advantage in terms of renal recovery. It means that once the patient comes out of this situation, the patient does not land up into your persistent renal failure. So which one, if I want to remove volume, I'll select a slow continuous ultrafiltration. If I want to remove Solutes plus volume, I'll took a continuous veno-venous hemofiltration or veno-venous hemodialysis or a diafiltration. Now you should know the difference between this because I don't have shortage of time because CRRT is a vast chapter. I'll definitely take another class for this. So remember this only, dialysis depends on the principle of diffusion from higher concentration to lower concentration across a semi-permeable membrane. So when something is diffusing, only the small molecules like urea, creatinine, sodium, potassium, bicarbonate, they will diffuse. But when you are doing hemofiltration, you are taking two concepts, ultrafiltration and convection. Here, it is working against pressure gradient. Dialysis against concentration gradients, so small molecules. Hemofiltration against pressure gradients, so not only small molecules, but also the bigger molecules. Along with that, it will draw a lot of fluid. So that is a solvent drag or convection. So the moment you remove a lot of fluid from the patient, if the patient is fluid overloaded, you remove that extra amount of fluid from the patient. But you have to also replace that fluid back to the patient. If you completely replace it, or you can partially replace it. So you can do both. You can control on the machine to see how much amount of fluid you want to remove. And you can decide on your therapy like that. So if we get a chance, we'll discuss this again. So when to start it? 5 studies, you'll get a question on EDIC 1 as well as EDIC 2. They may ask you ELIAN trial, AKI trial, ideal ICU trial, start AKI trial and AKI 2 trial. Except for the ELIAN trial, where they have seen that the early RRT, that is at KDIGO stage 2, they started. See, the mortality was 39.3% versus 54.7% when they started at KDIGO 3. But all the other trials didn't show much difference in mortality. But if you see the overall mortality in AKI, ideal ICU or start AKI, they all are hovering around above 45-48%. But here in Indian trial, it was 39%. So maybe an early start in a severe AKI stage might be beneficial. So this is basically when to start. So first of all, optimize your patient. If your patient is admitted to the ICU, do you have any absolute indications? What are the absolute indications? Hyperkalemia, fluid overload, refractory pulmonary edema, acute pericarditis, refractory cerebral edema. These are all absolute indications. So you start your RRT. If the patient, you don't have any absolute indication, see if AKI present or not. Yes, AKI is present. So optimize, first of all. Give fluids, seek the cardiac output, try to achieve your mean arterial pressure, decrease your intra-abdominal pressure, and then assess your stage, severity of AKI. If you find a severe AKI, don't wait, start RRT. But if you are in a mild or a moderate AKI, stage 1 or stage 2, see whether it is rapidly worsening, whether you have a hypercatabolic state, whether there is fluid overload, severe sepsis, you have pervasive hypercapnia, you have reduced renal reserve, or low probability of heart, you know that the patient is already in chronic kidney disease. I just can't wait. All right. And they have certain potential non-renal indications like lot of fluids, severe septic shock, acute liver failure, tumor lysis syndrome, severe electrolyte disturbance, hyperthermia, malignant hyperthermia, treatment is CRRT. Certain toxins are there. So you start your RRT. So it has been found that the dose of the RRT is around 20 to 25 ml per kg body weight of the effluent volume, but you prescribe a higher dose to achieve that lower dose of effluent volume. You have to anticoagulate your patient either with because otherwise the filter will clot. So either you anticoagulate with unfractionated heparin or with citrate. Remember, a lot of nutrients are coming out like amino acids, selenium, zinc, fat, glucose, everything is removed. So this is known as depletion syndrome. So we give a total energy intake of around 20 to 30 kilocalorie per kg per day, give good amount of carbohydrates, give good amount of fats, and never compromise on proteins. This you have to remember in AKI. Never compromise on proteins, and never compromise on your antibiotic doses. You have to increase your doses because most of them are removed by the CRRT. So maybe in cholesterol, you have to give a higher dose, maybe up to 15 million units. So these things you have to remember. So this type of questions will come. The questions will come like this that I have shown you. indications of RRT, which modality you specify, when to start, what dose, whether to use anticoagulants, when to stop, whether to go for nutrition, what about the antibiotic dosing. Definitely they will ask you. When I gave my exam way back in 10 years back, they asked me all these questions. Because in our time, I was the last batch where we are having a direct patient interaction. Now you are fortunate enough not to have that. So here you will have a virtual exam, but the questions will be the same and there will be more specific. They have their answers with them. So you have to be specific in your answers. So thank you so much. So I stop my screen sharing here. And if you have any questions, you can ask me. I'm not the best state of health today. I'm having fever. So, but still, as I promised, I took the class. And if you have any questions, you can post me in my, you may have my number from the organizers. You can directly question me. You can ask me. I'll try to answer them. Or you can directly one-to-one, if you want any help, you can question me directly by either mailing me or by questioning on phone. Thank you so much.